Welcome back, and apologies for the technological problems. I'm just going to hand straight over to the moderator of the next session on the presidencies. So I'm going to introduce Richard Bergström. So Richard, just over to you.
Yes, thank you, Bledin. So now you got your break already now. So I hope it's okay with you that we run until the top of the hour with this session. My name is Richard Bergström. So I'm with IQVIA these days, background running FPI in Brussels, and also working on the COVID-19 vaccine procurement, on which I've written a book, actually, if you think it's interesting to reflect on EU cooperation. I put together a panel here, which is it's going to be slightly more political compared to this morning, which I enjoyed very much, by the way. I think fantastic contributions from everybody. And I know that we're, to some extent, preaching to the choir here. We're all believers in, portability of data for primary care use and also for secondary use. And particularly, I come from big pharma, so I know a lot about R&D and the utility of usefulness of real-world data, for instance, for clinical trials. And you heard my colleague Dean speak this morning. So this is going to be a bit more political, the next 45 minutes. So I have 3 speakers lined up. Lucía Escapa also has some slides she will show in a minute. She works for the Spanish government, and she's head of cabinet for this General Secretariat for Digital Health and Transformation in the Ministry of Health in Madrid. I have Miklos Szocska, who was health minister for a record number of years for being a health minister in Hungary a few years ago. And also presided over the council presidency when the e-health strategy was adopted. And he's advisor now to the Minister of the Interior. Healthcare is actually under the Minister of the Interior in Hungary, interestingly. Then you also have Tapani, and Tapani Piha from you're back in Finland now, but you were head of unit, the e-health unit at DG or Sanko and then Santé, so you were very much involved also with this e-health strategy that Miklos was launching under his presidency, right? And Tapani has been involved now. He's been advising Sitra and the Ministry of Health, and he's been involved in TEDAS 1. And we heard a bit about TEDAS earlier, so I will let Tapani comment later on TEDAS 2 and how with everything else, right? So first, to just remind ourselves, I think this group here, all the listeners and watchers are well aware of the data aspects, and the possibilities and the challenges, right? But the political element, I'm not sure everybody is aware of, that the EHTS proposal from the Commission is a proposal, right? So it's now a decision-making. I think Mario described this a bit this morning, I think in a very good way, but I'll just remind ourselves of, also for those that are newcomers to the session now, is the fact that we have a decision-making process which is in parallel. It's the member states where the Council, European Council and its working groups, being presided by different member states every 6 months, it has one process. And right now it's Spain. It's going to be Belgium, and then Hungary, and then Poland. And in the interest of time, we didn't invite everybody to come to this meeting. I have my doubts that this will be wrapped up before that famous election that was mentioned this morning. So we have European Parliament elections first week of June. Then we're going to get a new commission. So effectively, we have a standstill for at least 6 months in decision-making in Europe. I think, Miklos, looking at you, I think this will end up in your lap. I think it's more realistic. That's why I invited you to be here today, So we have this parallel process, European Parliament. There was supposed to have been a position by the committee. There's several committees involved, actually, interestingly, on this file. It's both the liberties and justice people, it's the health people, it's the innovation and enterprise people. So it's a bit complicated, but it's been a little bit delayed, but we'll see when we get the Parliament position, and then it's the Council position. So without, so that I think is a good intro to you, Lucía. because Spain has the presidency of the European Council right now, which means that you're right in the middle of this. And I know you prepared some slides also to put the EHTS in the broader perspective, that this is not just one sort of free-floating piece of legislation or proposal. This is actually a bigger part of a bigger picture. So Lucía, over to you.
So, okay, thank you very much. Good afternoon, ladies and gentlemen, and thank you so much for this invitation to this session of the Digital Health Society Summit. It's a real pleasure to be with you. And I will use a presentation that I hope you are already seeing on your screens to go through the priorities of the Spanish presidency of the Council. And then I will also explain the situation with the European health data space as it is right now, the situation of Spain when it comes to the European e-health network for the provision of healthcare, cross-border healthcare. And I will also want to show you a wide overview of the Spanish digital health strategy and our situation in this execution. So to begin with, the priorities of our presidency in health, as our Ministry of Health explained, are oriented to continue building the European Health Union. And for this, we have three high-level priorities that are the protection of vulnerable people in the EU, and the preparedness and response initiatives for the new health alerts, and the alignment of the EU health agenda with the 2030 agenda and the One Health approach. And as a consequence of these high-level priorities, we have some political activities and some regulatory ones. As for the political priorities, we have three main areas of activity: the prevention and the healthy lifestyles. And some items in this part are, for instance, the childhood obesity or the chronicity. In the area of strengthening the capacities of health systems, I will go deeper in the digital health aspects, as the digital technologies can contribute in a decisive way to the quality, the sustainability, and the equality in the access of citizens to our healthcare systems. And finally, the third political area is the support and development of the EU health strategies. And here again, in these two aspects, cancer and rare diseases, the digital technologies can also play a most important role. As for the regulatory initiatives, we have some legislative actions that you can see on the left, and some other initiatives. We are keeping with the objectives that we set up at the beginning of the presidency, with the IMAFIS regulation, European Health Data Space, the SOHO regulation. We are confident we will be able to reach those different stages that we established at the beginning of the presidency. As you see, we are working with all the delegations in the Council to reach a general approach agreement to be able to start the trilogue process after the Parliament has its vote that is expected by the end of this month. So the second part I wanted to share with you is the experience of the Spain in the European e-health network that was created by the Directive 24 of the year 2011. As many of you probably know, in Spain, the healthcare is provided by the regions, the autonomous communities, and these regions are the ones providing healthcare to citizens under the coordination of the state of the Ministry of Health in a model that in fact looks like a small mini Europe. So every region has its own EHR system with different standards, different models, and we have been working since 2011 to develop a common, a shared EHR national health system record that is composed by 10 different standardized documents that are exchanged through a platform provided by the Ministry of Health whenever they are needed to provide healthcare to people from one region when they are in a different region. So because of this, two of these documents, the medical summary report and the patient summary, are in fact very, very similar to the ones that are exchanged through the eHealth network. And this is why we are very advanced in the joining of this to these services. You can see that most of Spanish population, in fact, more than 90% of people in Spain live in regions that have already joined the services of the eHealth network. And more than 20,000 pharmacies in Spain are nowadays able to provide medicines that have been prescribed in other European countries like Poland or Finland or Estonia or the Czech Republic or Croatia or Portugal. So I would say that from the primary use of health data, Spain is in quite a good position to begin with the implementation of the future European data space regulation. So this regulation, I know that most of you are well aware of, is structured in two big parts or two big blocks. First one deals with the use of data, health data for the provision of healthcare. My data are used by a healthcare professional to take care of me. And the second block is devoted to the use of this health data for other purposes different from the healthcare provision. So when we are talking about this primary use, I would like to stress some very important characteristics of this future regulation. It applies to the private sector and to the public sector. So every healthcare provider, every healthcare professional will be obliged to comply with the provisions of the regulation. The regulation recognizes the right of citizens to access and manage their own health data, to exchange those data with other healthcare providers as they see fit. It establishes a minimum data categories and some specific characteristics of the EHR systems that will be fully integrated in any EHR system that will be put into the market after the regulation enters into force. And finally, the regulation set up an infrastructure, My Health at EU, with some national contact points, some national digital health authorities, and some market surveillance authorities. This infrastructure that will be joined through also some services provided by the European Commission will be the one that will allow the exchange of primary health data for the purpose of healthcare providers. And for the secondary use of health data, the main points I would like to stress are first that this regulation, this future regulation, will establish a legal basis in the meaning of the GDPR to legal or lawful secondary use of health data for some specific purposes that are also regulated in this regulation. Again, it applies both to private sector and public sector data holders. So entities having some specific kind of health data will be obliged to provide this data for some purposes to anyone, to any data user that will ask for those data. The regulation establishes the protection measures and the warranties to protect the rights of the data subjects and establishes some entities that are the health data access bodies that are the ones that will have to receive the applications for data to evaluate the purpose, the nature of the data being asked for, and will be responsible for granting or denying the access. I want to insist that this regulation does not allow to access or to process directly any personal health data. By default, the regulation provides for access to anonymized data. And only when the purposes of the health data user cannot be obtained by using anonymized data, then the data health access body will evaluate this application and may provide access to data pseudonymized inside a secure processing environment from which the data cannot be extracted. So these are some points that I think that are very, very important that we are able to convey to the public opinion. So the regulation also establishes an European-wide infrastructure, this health data at EU. These entities, the health data access bodies, that are the ones responsible for publishing the catalogs of health data, receiving the applications, providing the secure processing environments, and granting or denying the access to the data. And finally, this is an exception to small and micro enterprises from the obligation of data holders. And the third and the last part of my presentation is just a summary of the Spanish digital health strategy that was approved in 2021 as one of the key elements in the National Recovery and Resilience Plan after the COVID pandemic. The challenges of the Spanish national health system are pretty much the same as any other health system in Europe. A greater medical complexity, increased life expectancy, increased mobility of citizens, and shortages in the availability of healthcare professionals, and finally, higher expectations of citizens about the digital availability of services and their access to those services. We believe that digital technologies, as I said at the beginning, can provide some solutions to these challenges, but we also believe that the application of digital technologies requires a different model, a model where technologies are applied to provide a common platform to support the work of healthcare professionals, to allow for them to exchange and manage knowledge, to ensure continuity of care, especially when it comes to chronicity, and finally, that empowers people to get involved in their own health. So this strategy has 4 high-level objectives that are people, training people, involving people in their healthcare processes, improving the performance of the system, innovation, and 5P medicine. So adapting our health system to the needs and the expectations of citizens. And finally, making sure that we do with good quality interoperable information to be able to take decisions, establish health policies, and evaluate those health policies. To develop all these big level priorities, we are working on 10 different functional areas with the regions. As I have said before, the healthcare provision is done by the regions. So in some of these functional areas, the projects are executed by the ministry with the provision of information from the regions. In other areas, like this one in green, the projects are developed by the regions in a collaborative model under the coordination of the ministry. And finally, when it comes to public health surveillance, the projects are developed in a shared execution model between the ministry and the regions. Our budget is not a small one, could be bigger, of course. But at this moment is 8,077 million euros, and some of them comes from national budget, and some of them comes from the recovery and resilience mechanism from the European Commission. The projects being developed under this strategy will finish by the end of 2026. And those projects are in 6 working programs that you can see on the screen. The first one, digital services. Here we deal mainly with aspects linked to interoperability, quality of data, and integration with Europe systems. Sustainability, efficiency, and equitable access to the EHS. Here we have areas of work like the management of pharmaceutical provision, data analytics, and medical image management and analysis. Here we have another one. The third is the digital transformation of primary and community care. We are working on the management and support process, including cybersecurity aspects, digital primary care centers digitalization, and telemonitoring and support to clinical decision. This digital personalized care is the last one we have launched together with the genomic one. And we will be focusing on developing models, processes, and resources for digital healthcare with a specific program about pediatric rare diseases. We will be expanding the catalog of genetic tests in the national health systems, and we will be deploying an information system to integrate this genomic information. And finally, we are working also with the regions in this national health data space, where we are starting with 2 use cases focused. The first one in the use of antibiotics in the national health system, and in the second one in the prediction of decompensations in chronic disease. So to summarize, our digital health strategy has many challenges as any other one, digital strategy, but we really think that the European health data space regulation for us can be a real opportunity, as it will be a tool to consolidate our strategy, to boost the work we are doing with all the actors involved, especially with the private sector, And finally, a very, very ambitious, uniform and homogeneous framework through the whole of the European Union for this European Health Union that we think that the COVID pandemic has taught us that we really need. So I think I have kept my time.
Thank you. Thank you,
Lucía. Very much.
Thank you so much. Very, very succinct. And it was really interesting that your reflection. You didn't say this explicitly, but I can do that. That some countries that are struggling with maybe having too much of decentralization may be able to benefit from DHTS actually to put things in place. I mean, I live in Switzerland, but I come from Sweden. And we have 21 regions, and it's all very complicated, you know. And Spain is the same, Italy is the same, UK, where I'm sitting right now in the office, you know, it's even more devolved, right? So I think that's an interesting dimension, Lucía. Now, I want to hold off with a question to you. I want to ask you and Tapani a similar question later on value chain and business model and funding and so on, but I want to let Miklos in a second. But I want to make a reflection, and that is that, you know, despite having had the cross-border healthcare directive, for those of us that have grey hair and we've been around for a while, we remember there were lots of hopes on interoperability of e-health systems and e-prescriptions and everything, right? And now I saw on your map, you know, we only have, is it 7 or 8 countries where e-prescription is working, and the only 2 neighboring countries that I saw was Portugal and Spain. So I hope that works, but otherwise, you know, I don't think it's any big use to have Estonia and Spain communicate so much. I don't think there's so much prescriptions being sent, but okay. Anyhow, now what happened with COVID? We got these certificates. Amazingly, in a few months, you know, or weeks, it worked. Yes, we did the procurement of vaccines as well that I was involved in, but the certificates, you know, what just happened? So when Europe wants to, it can do things together. So I think that's the way I see EHTS. Is there's a huge opportunity to do things differently. Learning from COVID as well. But with that, you know, Miklos, I'm going to let you in first because I know you have to leave a little bit earlier because you have to be on a panel with a lot of very important people. So Miklos, Hungary is different because you're much more centralized. And when you were health minister, you used a lot of data, also administrative data for healthcare reform. Rezoning hospitals, closing hospitals, and making a lot of decisions on care pathways and so on, you know. But I also know that you also have a very thriving AI industry, you have a very thriving tech sector in Hungary. So, and as you will be coming in, you know, taking over this file at some stage as well, what are your reflections on this for Europe? Because the whole approach is very altruistic, and I'll come back to that later on the money. Very altruistic, everything should be available for everybody. And as Lucía said, private sector data should also be available to everybody, including pharma company data. You know, so how do you see that in this sort of geopolitical, slightly challenging situation we're in, Miklos? Maybe a leading question, but Miklos, what are your thoughts on this from a more political perspective?
Yeah, first of all, I think I have a déjà vu. You know, in the Hungarian presidency, there was this e-health task force chaired by the digital Estonian president, Toomas Ilves. And, you know, 2 of the, I think, 5 lever points. One was liberate the data, and the other was integrate everything. You know, the first one, I think, my data, my decision. And at that time, it was quite embarrassing because there was a group of countries, we call them coalition of willing, basically Nordic countries, Finland, Denmark, Sweden, Portugal, Scotland, Malta, and Hungary. Those who either had or were aspiring to have integrated, national level integrated healthcare data systems. And, you know, I remember the moment when in 2013, the GDPR was emerging. I was the one warning the Finnish colleague that, hey, if GDPR goes through in this version, the Finns will have to get rid of the North Karelia public health database because you will have to collect data consent forms from the people already dead in those databases. And we were really embarrassed that for secondary utilization of health data, we were facing culturally determined countries like Germany, France. Gestapo and Stasi had left scars and had led interpretations in Germany that data protection is a huge political issue, or just like the French Revolution, after which it took 100 years to set the individual rights or the civil rights back on track. So there was this sort of division between the data protection fetishism and then the coalition of willing. So we were not able to progress in secondary utilization of health data. And let me give you another interpretation. Data is not just a privacy issue or a civil rights issue from the 19th or the 20th century. Data has parameters that one person's data is a medicine to another person. So I would not necessarily want to call it a secondary data utilization, but a data-driven health engine fuel. So if you can develop cure from data sets of a national health service to help another person in the data set avoid the adverse event or an unwanted complication or death, so then we should be more agile in utilizing data. And my understanding is that the way we approaching the present health data space thinking is sort of is coming from the research world, because research world were lacking data, and they needed more data. So they try to share data and they try to develop solutions on that data. And my understanding is that, for example, a data-rich country like Hungary or Estonia has to open up these strategic value data sets, then those countries who are technology rich but data poor, countries where you can only communicate health data on fax machines. So they might be sharking on the data-rich countries' exceptional values. So my understanding that in these regulations, we have to factor in that in Europe today, there is also a coalition willing that is capable of setting up data-driven health engines that need strategic investments. Because if these countries will have to liberate data, they might be data colonialized by technology-rich agents or tech companies or countries. However, data liberation stance I was taking in the previous decade, I was really radically pushing forward secondary utilization of health data. And in the Hungarian data e-health regulation, we deliberately chose the negative consent, just like in organ transplant. Up until you say no, you are an organ donor. Up until you say no, your data should be utilized for health purposes. So however radical pro-data utilization I was, now I have a fear because the speed by which AI solutions are driven. So if you have a high-value data set with 100% probabilities in it, if somebody teaches an algorithm on it, you are data colonized for the rest of your life. So I think we should take some strategic consideration and let's listen to data-rich countries' strategic considerations on the capability of developing or letting the health systems develop data-driven health engines. Finland or Spain or certain regions in Spain, Andalusia, Catalonia, Basque Country, we know them because of EU projects. And so there are system participants who are capable of doing that. So I think in that case, it is not data sharing, but strategically partnering with medical oath-related agencies or industries. That should be sort of a preliminary consideration before we open up everything for the non-solidarity outside medical oath agents accessing our data sets.
Oh, it's interesting. I've heard you speak before, Miklos, about this dimension that you have medtech and pharma companies. Okay, I'm a bit biased, but that somehow subscribe to a certain model of integrity, right? And now we have a new players showing up from elsewhere, and GDPR, works, even though it has some issues, with diverse implementation. Still, I think it's probably the best system in the world, for privacy. And now we have the chance to do the right thing. I would recommend everybody on this call, by the way, to also keep an eye on this AI regulation, which is coming in parallel, which has a lot of really interesting concepts in there, not the least on risk assessment and value chain business models. So I think, and I will let you, Tapani, comment on that later. This sort of whole those dimensions going forward. Bledin has kindly allowed us to extend with 10 minutes. Thank you, Bledin. I know Miklos has to go in a few minutes, but I will continue with Lucía and Tapani, and I have some questions in the chat as well here. But it's interesting what you say, Miklos, where you talk about you have data-rich countries, you have technology-poor countries, and now my Swedish friends would kill me when I say Sweden is data rich, but because of the regions, it's very complicated to do anything because you can't share things, right? So, and then we have the integrity issues and data privacy concerns, which are stronger in some countries than others. We may look at the multi-speed Europe in the implementation, but important thing, I think, is that we have a common framework and that the rules are the same, but we have to recognize that some countries and regions may move faster than others. So we just have to be aware of that. But this geopolitical dimension, Miklos, do you want to say, before you go, do you want to say anything more about that and the fact that we have these, you've used the term, and now with what's going on in Iceland, we're all reminded about tectonic plates, okay? But you've mentioned this term sometimes about the different sectors and so on. What are your final thoughts on that?
When we were talking about that, Hungary is relatively tech rich, so we have good data scientists. If you look on the names of who was working for Tesla and who was working for Google, so you see Hungarian names and they are coming home to Hungary to have summer courses. Just let me use the human genome analogy. So if you carry away a piece of the human genome and put a patent on it, then you have to negotiate with the patent owners to put together the entire human genome. I think, fortunately, humanity did another route. So my understanding is that if we open up, we should open up strategically, and it should be not carrying away the data samples, but carry on the data samples on some joint frameworks. So my understanding is that we should not forbid German industry using Hungarian data, but yes, then we have to cut the strategic agreements with the industries that find, okay, what is the joint value? We work together, data science, equipment, all that stuff, and we trade in a third country. So my understanding that if we increase the level of strategic discussion, then we could reach European competitiveness. That's and I'm really worried because EU and Europe is a risk sharing and solidarity union, and the rest of the world, not necessarily.
No, we have universal healthcare here, single payer systems, and even if we have two, three countries that have private insurance, that's still obligatory. So, I think you make a very, 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 very good point. And again, in this AI regulation text, particularly the one from the Parliament that was adopted, really interesting reading. I mean, I'm on a very steep learning curve, I keep saying, on foundation models, This is about, you know, revenue sharing and building in some controls. Now, Miklos, you need to go because you have to be on a panel in a few minutes. Before I move to you, thank you, Miklos. Thanks for coming. Now, before I get to you, Tapani, I had one question in the chat here for Lucía, and if you can keep this short. But the question is really about, you know, the extent of data sets that could be accessible under a new national scheme under this data access board. Okay, so are you thinking about going beyond pure health records? Because I mean, you have other data sources. You have potentially patient-generated data. You have administrative data. What are your plans?
Well, as you may have seen in the proposal for the regulation, the health data that will be available for secondary use are indeed much more than those ones coming from the health record. In fact, almost every kind of health data that some company or body or institution or organism may have, for instance, a company doing blood analysis, these data sets will be under the scope of the regulation. So it doesn't matter if the data holder is a private company or a public institution, but if you want to do some kind of, for instance, research or innovation, you will be able to make a data application to this kind of entity and ask for this data set that you are interested in. So it's very, very wider than the health records.
Well, and it came up this morning. I can't remember who raised this. So there was a question in the chat about biobanks and pathology data, yes, lab data, right? I mean, you have potentially, yeah, we have not yet analyzed samples. So if somebody wants to say, okay, yeah, if you have a view on that, if someone shows up and says, I'm willing to pay for sequencing for all these samples that are in this population, is that subject? Would that fall under this regulation that you have a right to do that? Of course, the cost would have to be paid by someone like this, if it's a company or a foundation, I don't know. What quick view on that, Lucía?
Well, it depends. It's not so easy. For instance, clinical trials have their own regulation. So you will not be able to ask for data from clinical trials until those clinical trials have been completed in the sense of the regulation applying to clinical trials. On the other hand, if you are going to ask for some data that are subject to IP rights, you will be able to get them as far as those IP rights can be protected. So there are limitations to the kind of data and the kind of sources you can apply for. And the money you are going to pay for this is for making the data available. The example you have made is you want to obtain some new data. This is not what the regulation is about. The regulation is making available health data that are already in the data holder's hands, so to speak, not to creating new data because you want this data.
Oh, that's interesting. That's helpful.
It's a different thing. You want some data that you believe that are already available. Then under the regulation, you can go to the data holder and say, okay, I believe, or at least there is a catalog. You have seen in the catalog, there is some data set you want to get. And then you go to the data holder and you say, you have this data set that is listed in the national catalog. I would like to use this data set for this purpose and this one and this one.
Right. No, that was very clear. Very good. Very good. Now, turning over to you, Tapani, again, we have another 10 minutes here. So I want to particularly, you should say a few words about, because you wrote this sustainability report, which was a final delivery of the TEDAS joint action, which we heard about this morning. But I want to particularly point you in this direction. It came up this morning, and it's one of my themes, Lucía mentioned IP, but I mean, there's more to it than that, So I come from Sweden, and I know we are a very data-rich country, and we have all these registries, and they are funded by selling the data. So, IQVIA, we buy data, we maybe pass on the bill to pharma companies. Pharma companies pay, we have foundations, institutions, grants, so you fund an ecosystem of people. You may have 15 employees or something, and you do OMOP mapping, and you do all this data cleaning and so on. And you and it's not that people are pocketing money by themselves. It's not for profit, but these are private institutions, public institutions. So it could be part of healthcare, it could be part of university, hospitals, and so on. So Tapani, what's the reflection? Because the whole EHDS proposal smells of altruism and everything is for free. How are we going to make sure that there is a value chain and that all these institutions can continue funding their work? Tapani, what's your view on that in particular? But then in general, a few words about your reflections on the sustainability.
Yeah, thank you. Very often when we in the health sector, we speak about things, we don't think about money, because that is something which is just flowing in. And I was very happy to see that Lucía was speaking about the Spanish national strategy, which is funded by nearly 900 million euros. So it shows that if you want to do things, you need to fund it. You need to find money from somewhere. But we have been very poor at identifying those sources. And of course, the legislative proposal made by the Commission, because it's of its nature, it doesn't tell where the money is coming from. And then in this work package where we looked at the sustainability of the European healthcare space, we actually tried to see what are the possible sources of funding. But I must say that our discussion, again, was mostly looking at the kind of public sources. The assumption started from the fact that most of the healthcare organizations are publicly funded in most European countries, not all of them, but many of them, or some kind of a solidarity funding. Then the other question was that we were asked that how these new health data access bodies, where their money is coming from. And there actually we found a rather comforting message that the health data access bodies, their operation is not that expensive. So that is something which can be financed by state budget. We looked at the financing in Finland, and we looked at the financing in France. And so there was kind of a positive message is that yes, that the money needed is probably mostly needed in the health data holders. So that if the hospitals, healthcare centers, or private providers, they need to upgrade their systems. That is one big question, but one big cost. And it might be also a bit difficult to motivate people to do that funding. I must say that I had to disappoint you, Richard. We didn't look at too much about the private funding or the business models. But of course, their time will come a bit later, I would say. One thing when we looked at this issue of implementing the European health space and the financial issues, one of the findings we very quickly came into, it's not only about money. There are many sources of sustainability. If we want to have a sustainable system, it's not only about money, it's about solid legal base, it's good governance, it's trust of citizens, professionals, and politicians that this is useful exercise. And then also that, of course, we need to have a reliable and secure IT system. So those are all elements in this sustainability. Then I would like to comment one thing you, Richard, said, that you looked at Lucia's maps and said that the progress in electronic health records and e-prescriptions has been slow. Yes, I realized that 5 years I left the commission 5.5 years ago, and still we are making progress, and not as much progress as I wanted to make when I was still there. But I would think that one of the findings in our sustainability plan was that also building the European health space will be slow. It won't happen overnight. Even in Finland, which started from a rather good position, it took us years before the FinData agency, the health data access body, started reaching a cruising altitude. And now after 5 years, it's not yet necessarily there. So we need to actually hold our horses a bit and to understand that it will take lots of work from the countries, and it won't happen overnight. But if we don't start now, we will never get there. And then the last thing I would like to comment on this discussion in this panel before was what Miklos was saying. And I hope that he would have the possibility of hearing what I'm now saying, because we actually identified this question of fair data economy as one of the key points in this success, as one of the success factors of the European health data space. That if all countries and all stakeholder groups don't feel that they are getting their fair share of this benefits which are coming from this data use, then it won't be as successful as it could be. So actually, perhaps the final point is here that when you look at the sustainability, it's not only about money, it's about many other things, including trust and fair data economy and other issues which are needed. But I think that what is now coming is that I hope that the Spanish presidency, I have heard that you have been working very hard and successfully, that we will get this legislation through relatively quickly. And then this sustainability plan I was discussing, that was work of the TEHDAS 1. But now we are planning with the 30 countries, including Spain and Hungary, that we are planning TEHDAS 2. And that plan should be ready by end of January.
Right. Thank you, Tapani. So you've heard the expression on this dimension of fairness, and we touched upon it throughout the day. You know the expression, too big to fail, which is what they say about banks. Now the saying in Brussels is you have companies that are too big to care. So the whole thing is, are we really going to, as Miklos said, is this really going to be given to everybody, and some people that may not care. I think my bias is that the incumbents, so pharma, medtech, regulators, and Europe, the system sort of is much more mature in that sense. And therefore, I really hope that there's not going to be any surprise political developments in the next few months, because you remember what happened when one former prime minister in a former EU member state, who now is back in cabinet, by the way, said that every NHS patient is a research patient. What an outcry, right? So I will finish off, Bledin, handing over to you by quoting a colleague of mine, Anna Martling. She's professor at Karolinska Institute, and she's dean of research. And she made the point the other week, we were in a panel together, and she said, we need to sort of flip this whole debate. I demand as a patient that my data is used. My data must be put to use to benefit society, both on myself and society. So this whole opt-in, opt-out, So maybe we should plot something, Bledin. We've been talking about that. There should be a movement about why data really must be used. But then you need to have the framework, the legal framework and the ethical framework, the value chain, the business models, all of it, right? So there's a lot of work ahead of us, but I think we're all enthusiastic. I know I'm preaching to the choir, but I wanted to throw in some dimensions that we shouldn't be naive about. Let's not be naive about this, because this is big stuff. Bledin, over to you.
Fantastic. Thank you so much to the panel. really informative and quite thought-provoking, actually. So thank you very much for putting up with some of the technology problems at the beginning, but it was very worthwhile. I hope everyone agrees. Thank you very much.